I
Sure.
always assume that everybody will know who you are because I've been reading about you and watching your presentations for years, but some people may not know who you are. So this is Kenneth Zucker, and he is probably the foremost expert on gender identity and helped to develop the guidelines for the American Psychiatric Association regarding gender identity disorder, which is now gender dysphoria, and has just been really at the forefront of these issues. In addition, he practiced in Canada, is that correct? And he tended to embrace a watchful waiting approach, which um, ended up garnering some ire from transgender activists. I don't know if you prefer Dr. Zucker or Ken or Kenneth.
My last name's pronounced Zucker, like
Zucker.
hooker.
Oh, okay. So I guess if I'm going to do it, I better call you by the right name. So, Dr. Zucker, you were just talking about the conversion therapy legislation in California with regards to transgender, probably specifically children.
Well, I think that the original California legislation was targeted at children and adolescents. As I said, I think legislations vary whether or not adults are scooped in, but in Ontario, for example, the legislation that was passed a few years ago under Bill 77 is really talking about minors, particularly minors who can't give informed consent, which I'll get back to in a minute. But what the trans activists, the clinician activists, the politicians did was that they pinned the gender identity tail onto the sexual orientation dog. And now all of the legislations lump gender identity in with sexual orientation. Most politicians probably don't even quite know the difference. The legislation, I think, also does not take into account developmental issues, but it's very political. However, if you read the different legislations where there are these forceful statements like, you know, you cannot try to change a person's gender identity, they all have this does not apply clause to it. And in the clause, one of the things that it says is that it's okay to engage in identity exploration. Now, there are two issues. For example, in Ontario, it talks about minors who can't give informed consent. So let's say a 15-year-old comes to a clinician and says, I'm confused about my gender identity. Can you help me? Well, number one, if you deem the minor capable of giving informed consent, then the legislation doesn't apply. And you can engage in identity exploration with the adolescent. Now, what does identity exploration mean? Nobody knows because it's not defined. And to my knowledge, nobody has accused a clinician of violating the legislation, probably for different reasons. Number one, let's say adolescents or their parents who want a clinician to engage in exploration with their kid aren't going to make a complaint about you. Parents or adolescents who aren't really interested in identity exploration, which is fine, well, they're not going to see a clinician who is open to identity exploration, so they're not going to complain. But what I find insidious about the legislation is that it's really targeting little kids
Right.
as
And
young as age 3, who of course can't give informed consent. And because, the average clinician doesn't read the fine print, clinicians just think, oh, one can't offer anything other than, quote, affirmation or acceptance, which is not true. But the legislation is successful in the sense that it's probably terrorized clinicians into wanting to stay away from this population, because why would the average clinician want to risk their
right.
career by wading into a political hot potato? But I think that, basically the politicians are ignorant, and I think the activists, knew exactly what they were doing, which is to try to intimidate clinicians in engaging in exploration with both children and adolescents, where either parents or the kid themselves wants to.
And I was wondering, I wanted to kind of read to you a synopsis of the report that my school psychologist made on me. This was back in the 70s, so they might have been influenced by your work. I'm not sure when you started publishing, but
Probably not.
but basically what the report says is Aaron wants to be a boy. I was acting out so much in school that between kindergarten and first grade, I had changed so much that the school psychologist and the teachers and principals were very concerned. And so, the conclusion of the school psychologist was that Aaron wants to be a boy. And the plan that she came up with for my parents and my teachers was to reinforce Aaron's idea of women in general, read about famous women, try to expose her to strong and talented women. They set up a small group of 5 or 6 kids with communication problems. They suggested exposing me to activities like brownies, where I'd be around other girls. Build up her strong points so that she knows that we like her and not just what she does. And then it says, she doesn't trust anyone or want to rely on anyone. We need to find ways to establish trust. So that's what happened in the 70s when I was a little kid. They didn't affirm me in any way. At no point did anybody say, oh yes, you're definitely a boy. Go ahead. We'll call you by Timothy, which was the name I wanted to be called. We'll allow you to transition and acknowledge you as a boy. But I get the feeling now, under the same conditions, if I were in school now as a 6-year-old, that it's likely I would be encouraged to accept that I was born in the wrong body. And I'm just wondering how it is that we went from, this very simple prescription from a school psychologist on how to address my behavior issues to now putting kids on puberty blockers and telling them that they're born in the wrong body.
Well, I think I can answer that in several ways. First of all, if one looks at the follow-up studies that have been done on children, and by children I mean anybody who may have been seen by a clinician anytime between, say, the ages of 3 and 12, and then they're followed up in their late adolescence or adulthood. The majority of kids who had gender identity disorder, or what we now call gender dysphoria, did not persist or continue to have gender dysphoria. One percentage that is often thrown out is like 80% desist, though the percentages vary from one study to the next. In some studies, the desistance rate was as high as 100%. One study of girls, it was 50%, but the ballpark is around 80%. In our 2 follow-up studies in Toronto, the desistance rate for girls was 88%, and it was also 88% for boys. Now, one criticism that some people make of these follow-up studies is that, well, not all of the children met the criteria for gender identity disorder, gender dysphoria. They may have had some traits, but they were sub-threshold. So a critic might say there was really nothing to desist from because they didn't have anything in the first place.
And yet, but the definition they're saying is persistent, insistent, and consistent, which is, I'm guessing that that a kid wouldn't end up in your care if they didn't have insistent, persistent, and consistent.
Not entirely true. I mean, threshold for why a parent might seek out a clinician is going to vary, but
okay, so
there's a few things to say. One is that a number of the follow-up studies were done before the DSM actually had a diagnosis, but if you read the descriptions of the kids, their behavior was consistent with the diagnostic criteria. Number two, yes, it's true that in the follow-up studies that used the DSM criteria, not all were threshold for the diagnosis. And when one looks at the sub-threshold kids, a very small percentage were judged to have gender dysphoria at the time of follow-up. But in a paper that I published in 2018, I looked at 4 studies that actually used the DSM criteria. And of the kids who were judged to have the diagnosis in childhood, 67% did not have gender dysphoria at follow-up. So that's still a very high percentage.
Yeah.
Now, of course, then the critics might say, well, the criteria are lousy. And to that I would say, well, then come up with better criteria.
Well, and one of the issues is
there's one more thing I want to say about it, about all of this, is that if you look at all of these follow-up studies that, go back to the 60s and into the 2000s, and one asks, well, if these kids had some type of therapy, what was it? And if you look at different papers, the kinds of therapies, if they had therapy, was quite variable. It could have been just recommendations given to parents, or it could have been parent counseling, or it could have been play therapy, it could have been behavior therapy, it could have been psychodynamic therapy. But the one type of treatment that these kids didn't have is what has become more common in the last 10 or 15 years, which is what I call a gender social transition. So to go back to, what you were saying about yourself, there are some clinicians nowadays who might say, oh, your child is trans, therefore you should support your child in living in the desired gender. So change a name, change the pronouns, change what they wear, change their hairstyle, and basically affirm your child as the other gender. And one point that I've made over the past couple of years is that it's important to realize that that is a type of treatment, just like these other types of interventions are also treatments.
Right.
But I would predict that when people get around to following up young children where a gender social transition has either been implemented by parents themselves on their own or at the recommendation of a teacher or a psychologist or a psychiatrist or a social worker, the rate of persistence will be way higher than these follow-up studies that are in the literature to date. And I think that one could make the argument that there may be this association between the type of therapeutic approach one is taking to reduce gender dysphoria, because you could say that all of the approaches, one way or the other, are designed to reduce gender dysphoria.
And that's actually a really interesting point, because obviously the goal is to help kids who are having a difficult time, who are struggling. One of the things in my case that the reason that I actually got interested in this, 2 years ago, I never even gave this topic much thought, but my gender dysphoria, my trans identity as it would be called now, was the direct result of a sexual assault that occurred, where I was sexually assaulted and my brother wasn't, even though he was right there with me. The men who assaulted me said that they were going to cut his penis off if I didn't cooperate. And so I did. And it was like, I didn't consciously say, I'm going to be a boy now, but that's what my coping mechanism was, is I will never let that happen again. If I'm a boy, that won't happen again. And that's why there was such a sudden shift between kindergarten and first grade. And, the oppositional behavior and the aggression and all that, me trying to be a boy. And my concern is that if a child is affirmed and their gender dysphoria or trans identity is the result of something like that, a trauma, or, even a misunderstanding about what gender identity means. But in my case specifically, if I had been affirmed, then, the self-hatred that I had and the shame that I had and the belief that being female meant being vulnerable and a victim would have been affirmed. And that's what got me involved in this, is the idea that there are children out there who might really need good clinical intervention to help them, work through these issues. And they may not get it now because of this new approach.
I think it reflects the different theoretical and philosophical perspectives that clinicians have. So the, let's call them the quote progressive clinicians, ironically, are biological essentialists. They adhere to a born that way narrative, and usually progressive people are anti-biology. And certainly I've seen reports by, let's call them affirming clinicians, where there's really no interest in exploring possible underlying factors. They sort of, it is what it is. If they took just the average history and they heard that, a 6-year-old had been sexually mistreated, one would hope that they would at least think about whether or not that's an important parameter that needs to be explored. But I think it depends on one's philosophy and theoretical perspective. And I think some parents are also essentialists. Like if you read the public narrative of the parents of Jazz Jennings, who's sort of like the poster kid for early gender transition, you can find a comment probably written by the mother saying that Jazz was born with gender identity disorder and diagnosed at the age of, let's say, 3 or 4, but it's an essentialist perspective. A slight sidebar, how do you think, if you're willing to say, how did you resolve the issue for yourself?
Yeah, that's a good question. I actually persisted with the the sort of demand that I was a boy. For a number of years, I had lesbian relationships when I was a child, because that was part of, you know, the identity that I was going to cultivate girlfriends so that I could be the boyfriend. And I was probably more aggressive in a way that I'm not proud of, until I hit puberty. Like so many other kids, when I hit puberty, suddenly it sort of shifted, and I realized that I wasn't attracted to girls. And um, I struggle. I struggled probably, well, I still probably struggle somewhat in sort of the idea that accepting the idea of that I align with being a woman. I don't know if that's because of my early childhood experiences, but I honestly don't know what it feels like to be a woman. I know that I am a woman. But I would say the self-hatred that I had for my body was really resolved when I had a baby. And they put this beautiful baby in my arms, and I looked at her and I thought, this is a pretty darn cool body I have. And it was really the first time that I stopped having that dysphoria with my body. But I still really, I was thinking about it even today. I put makeup on when I do these interviews, and it's not because I feel like a woman. It's because someone suggested that it would be good if I wear makeup when I do these interviews. So when people say that I'm cisgender, or that there is such a thing as cisgender versus transgender, I get really confused, because I don't know what it feels like to be a woman other than the fact that I am. I don't know how anybody who isn't a woman could say that they know what it feels like to be a woman, when I don't even know what it feels like to be a woman. And a lot of the women that I talk to say, you know, they are women, but they don't identify as women. They just know they are women because of biology. And so I wonder if on some level, this is like, I was brought up in the 70s, and this is almost like it's like we're talking past each other almost, because in the 70s, the goal was almost to allow, to get rid of these gender roles, to get rid of these kind of restrictive ideas of what it was to be male and female. Um, and now it seems like we're kind of regressing back, and transgender activists are saying, well, if you have these stereotypical behaviors of a female, then you're female, and or you are a woman, and if you have these stereotypical behaviors of a male, then you are a male. So it almost seems like we're regressing in our understanding of what gender is. I was just curious, do you believe that it's possible to be born in the wrong body?
I'll get to that in one
Okay.
second. Yeah, in the 60s and 70s, non-sexist child rearing was trendy, or celebrating androgyny, a
Mhm.
mixture of masculinity and femininity. The psychologist Sandra Bem promoted that and became very famous. But Bem also, I don't think, challenged, basic gender identity. It's just, I can be a female and do anything, or I can be a male and I should be able to do anything. If we telescope up to modern times, I mean, there is a certain irony in that your average liberal developmental psychologist who studies gender, or your average person in the community, is more or less, not particularly in favor of gender stereotypes. Nobody's willing to acknowledge it, but the exception is when it comes to trans kids, where everybody thinks it's so adorable that they're so stereotypically gendered, except in an inverted way.
Right.
So that's a certain irony. Now, to your other question about, born that way, it is probably, theoretical fence sitting, but if one says, that gender identity differentiation is multifactorial, it means it's a combination of various factors, including biological ones. And I've done research on both biological and psychosocial influences. The reason that I think that biological factors alone is too simplistic is that how would we explain why, under certain conditions, a substantial number of kids with gender dysphoria don't continue to have gender dysphoria? If biology explained 100% of the variance, you shouldn't see that change in gender identity. But I think there are a number of factors that include predisposing biological factors that may be operative in some people. But I want to go back to something you said earlier. Is there a difference between saying I'm a female versus I'm a woman? Or do you use that interchangeably?
I used to use it interchangeably. And it never even occurred to me that there was a difference until I started to sort of wade into this gender ideology. And once I started, I actually started testifying about my experience to state legislators over my concerns about the conversion therapy bans, because the kind of help that I got likely would have not been available to me when these bans are passed. And so it wasn't until then that I even realized that there were biological males insisting that they were women, or biological females insisting that they were men. I had no idea. I was very aware of transgender people. I was very far liberal, and I was donating to the local LGBT organization. So I had a lot of compassion and understanding for adult transgender. I was good friends with a woman who actually had gone through a medical transition. So but I always thought of it as transsexual in my mind. It wasn't that there was no insistence that their biology had changed. So now I very much think about the kind of labels that I use when I talk to people, because there is this idea that a trans person becomes the sex, not just the gender, but the sex that they identify with, which I think is very problematic. And that's why I say things like, I'm a female. I don't know what it's like to be a woman, because it seems like woman and man are now these sort of ephemeral terms that are being used as an identity. And I'm not entirely sure how you go about defining them.
Well, if gender identity is a part of one's sense of self, it's very subjective and phenomenological. So if one asks somebody, what makes you feel like a woman, or what makes you feel like a man, you're going to get different answers. Now, I think that when some transgender people declare, let's say you're born male and you say, I'm a woman, I don't think that person is saying that they are biologically female.
Actually, they are. I have.
Well, some people might, but
yeah, at least the activists are really pushing that narrative that say their penis is actually a female penis, and that chromosomes don't define them. And I was actually quite shocked when I discovered this, because it sounds so absurd.
Right, but that's more a political maneuver.
Mm-hmm.
If you were talking to somebody, say privately, they know what their biological sex is, and they know that biomedical treatment is designed to approximate the phenotype of the desired gender, but they full well know that biomedical treatment doesn't alter your sex chromosomes. It doesn't alter what your internal reproductive structures are or were. So it's more a political maneuver more than anything.
That's interesting that you say that, because I have wondered. I mean, I've never talked to a transgender person and challenged them. And it sounds, I mean, you definitely have had more experience. You have, you know, you work with people who identify as transgender. And so you feel like this narrative that's out there is more political, and that internally they realize that this is just a disconnect with the way they want to present versus how they externally present without modification.
Yeah, and I don't know what percentage of trans adults would make those assertions, but the average adult person who has gender dysphoria or who has a trans identity, they know what their biological sex is. That's
well, otherwise they wouldn't try to change
part of their dilemma.
Yeah, that's part of the dilemma.
The stress caused by the incongruence between their felt gender and their sexed body.
Well, and one of the I guess the questions that I have, and I was surprised. I heard you in another interview say that that your clinic, that many of the kids in your clinic actually are on puberty blockers, and that really surprised me, because one of the things that I think about is sort of what's going to be the less harmful thing to do, what is going to, you know, in the long run. And when I started speaking out, other people have talked to me about having similar experiences to mine, about developing, you know, these ideas of being the opposite sex, and a lot of times it was a coping mechanism. And so I think about, like, I don't know what percentage of kids, well, we know that there is a great deal of desistance when they get older, but of the kids who don't desist have underlying issues that maybe could be helped with therapy. Whereas if we put them on puberty blockers, then we know from the research done at the UK that these are kids that are likely going to go on to cross-sex hormones, and that those are going to damage their bodies. These are not, you know, they're not benign interventions, whereas watchful waiting, it seems to me, is a benign intervention. And so I'm trying to figure out, how do you, as a clinician, determine whether or not a child should be put on puberty blockers when there really isn't a test for transgenderism, or who is going to persist with those feelings long term?
Well, I can try and answer that in different ways. First of all, with rare exception, there's no laboratory test for any psychiatric diagnosis.
Right. Yes.
So I don't particularly buy that argument that as a clinician, if you're working with a set of diagnostic criteria, you're making a judgment whether or not somebody meets the criteria or not. One of the advantages of working, say, with children and adolescents is not only can you use what the kid has to say, but you also have parents as informants, and you're looking at the degree to which there's agreement. But I think here it's useful to introduce a developmental perspective. So back in the day, when the Toronto clinic was started in 1975 or so, and as the clinic grew, we always saw way more children than adolescents. So in the 70s, 80s, 90s, early 2000s, we didn't really see a lot of adolescents with gender dysphoria. Now that's changed incredibly now in the year 2020, where everybody is seeing way more adolescents than in the old days. But let's go back to the old days. So, you know, in the 70s, 80s, 90s, we would see adolescents who often had an early onset history of gender dysphoria that continued into their adolescence. And our view at the time was that these kids were pretty consolidated
By the time they're in
in their gender identity. And back in the old days, there weren't many options other than to socially transition, and one had to wait to turn to the age of 18 where you could refer them to an adult clinic where hormones might be administered and so on and so forth. So in the mid-90s, the Dutch came up with this idea that you could help adolescents who have persistent gender dysphoria by introducing hormonal suppression so their bodies would not masculinize or feminize further, and maybe that would give them some space to kind of figure things out. And when we first started to suggest hormonal blockers for some of the adolescents we were seeing, in part, it was influenced by our perspective that even if, say, a 15-year-old wanted to become more comfortable with a gender identity that was more congruent with their birth sex, there wasn't a lot of clinical evidence to suggest that that was going to happen. Just like the vast majority of adults with gender dysphoria, even if they would like to lose it and be more comfortable in their own skin, it doesn't happen in the vast majority of cases. So that was one of our motivations for introducing hormonal suppression as a recommendation. And in a paper we published in 2011, we would recommend it in about 2/3 of the kids we were seeing, which was very similar to what the Dutch were recommending for their adolescents. Now let's jump up to 2020, where I think the clinical situation has become much more complicated in that we're seeing a much more heterogeneous population of adolescents with gender dysphoria. So for example, Littman's coined the term rapid onset gender dysphoria, mainly in people who are born female, where parents would basically say that their adolescent kid never showed any signs of gender dysphoria until, let's say, grade 7, 8, 9, even later. And for many of these parents, the gender dysphoria seemed to, quote, come out of the blue. And what I can say is that I think that there are many clinicians, including myself, in North America, probably in other parts of the world, the UK, Scandinavia, probably in Europe, where there are more and more of these kids who are presenting for clinical care, who we would never have seen back in the early 2000s, in the 1990s, and the 1980s. And in fact, by the mid 2000s, we started to notice in Toronto that all of a sudden we were starting to see more adolescent females and adolescent males, which was an inversion of the earlier sex ratio. When we published a paper in 2015 showing this change in the sex ratio, both in Toronto and also in the Amsterdam clinic. And since that paper, I've been working on a much bigger study looking at the sex ratio from many different clinics across North America, Scandinavia, Europe, community samples, and everybody is seeing this shift where there are more females identifying in the transgender spectrum. Now, if we go back to this idea that there's much greater heterogeneity, that, in my view, suggests that one has to think hard about whether or not the original Dutch model, in terms of so-called eligibility for hormonal suppression, applies across the board. So, for example, if you read the original Dutch eligibility criteria, one of them was that there had to be this lifelong history of gender dysphoria. Well, suppose you're seeing a 13-year-old who has just declared that she's a boy 6 months ago. That's not lifelong. So would it be more prudent for kids like that for there to be some period of exploration and therapy of, well, what's going on? Like, why has this appeared suddenly and out of the blue? Or should one just do watchful waiting and say, well, you know, you might be feeling this way, but come back and see us in 6 months. And I think, again, it's going to depend on the theoretical and philosophical approach that a clinician adheres to. So if you are an essentialist, you know, you might say, well, if a kid says they're trans, there's nothing to explore. And they might recommend hormonal suppression regardless of age of onset. And I've certainly seen reports and have met with families where they've met other clinicians who take that point of view. I don't agree with it because I think this new subgroup of rapid onset or late onset girls with gender dysphoria, they're very complicated kids. Now, for some of them, after a while, I might recommend hormonal suppression, but in other kids, I don't. And because they're this new subgroup that is being defined only over the past few years, we know very little about the developmental course of these kids. Is it going to be more variable than the course one might see in the classical early onset kids where the gender dysphoria has persisted into adolescence? And we need to do the studies.
And based on what I'm seeing, I've talked to a number of these girls who had what would be considered rapid onset gender dysphoria. Some of them actually did go on puberty blockers or cross-sex hormones and then have desisted. And that's a population I think we really need to look at. And for a lot of them, there are these underlying issues, either a trauma, a sexual assault, or maybe internalized homophobia, or feeling uncomfortable with the way their body's developing because suddenly they're sexualized. So I think that these girls are really vulnerable, and that it's important to look very carefully at what's happening. And the other question that I have is, and this is something that just really kind of bothers me as a woman, as a person who has insurance, as a person who seeks medical care, that there are a lot of things about my body and my appearance that I would like to change. I don't know of any woman who's 100% comfortable with her appearance, and yet our insurance providers and Medicaid and, you know, where you live, probably the health services don't tend to affirm these desires and don't pay for them. And so part of my confusion is, say I am a very flat-chested person, and say I identified as a large-breasted woman. I identify as a very female, feminine woman, and part of that would be to have large breasts. But my insurance company won't pay for that because they consider it cosmetic. So why is it that one group gets interventions to modify their appearance? They're basically kind of cosmetic treatments, whereas other groups aren't provided that because it's not considered medically necessary. So it's almost like a degree to which this body dysmorphia or dysphoria impacts them, or how do you respond to that?
Right. One thing, by the way, this is a sidebar, is I don't think that most adolescents, for example, with gender dysphoria would meet the criteria for body dysmorphic disorder. Sometimes parents will talk about it. One has to be careful in using the terms interchangeably. So if you read the diagnostic criteria for body dysmorphic disorder, it actually talks about how the diagnosis shouldn't be given if the discomfort in one's body is basically because of gender dysphoria. It isn't like, you're not happy with how long your earlobes are or what your nose looks like and so on and so forth. But anyways, so
Just interrupt, because this is just intriguing to me. So could a woman who maybe isn't a very attractive woman, who maybe is a more masculine appearing woman, have gender dysphoria because she doesn't feel womanly enough?
I've seen a few adolescents who have obsessive compulsive disorder, which sort of then slides into body dysmorphic disorder, and then they start to wonder if they should become a man. But it really seems like it's secondary to OCD or body dysmorphic disorder, but I don't think it's that common. Now, to go back to your point, sure. I mean, where does one draw the line between cosmetic surgery and insurance covered gender affirming surgery? It's a very interesting issue. And what's also relevant is that activists and clinician activists speak out of both sides of their mouth. On the one hand, this isn't a mental health condition. It should be deleted.
Right.
Yeah,
and they're pretty adamant about that.
But it should be paid for anyways by, health
and that's where the disconnect
system.
is for me, is that how can you say that this is a normal developmental path but then require medical interventions?
Well, it's very political. So, the American Medical Association will say that, gender dysphoria is a serious medical condition, and therefore insurance companies or, the US government's healthcare system should cover biomedical treatment. So you use the diagnosis when it's convenient, and then you disparage it when you think it's too pathologizing. And it's also interesting that I know there are some clinicians who work with children and adolescents who don't even use the diagnosis of gender dysphoria, and they'll put in the file that the child or adolescent has an unspecified endocrine disorder so that they can get reimbursed. Now, of course, if you said, well, what is the unspecified endocrine disorder? They would probably say, we don't know. That's why we put down unspecified. So there's a lot of gamesmanship and Gets into the philosophical debates about what is or isn't a mental health diagnosis.
Well, and that's the other interesting thing is that gender dysphoria has clear criteria. I definitely met the diagnostic criteria for gender dysphoria up until I was an early teen. I'm not sure about gender identity disorder because that required the premise that the person didn't feel like there was an advantage, I think, to being the opposite sex. I'm not sure, but it's a little bit more nuanced. But right now we have the gender dysphoria diagnosis, but then we have transgender, and they're not necessarily the same. So you can have somebody who claims to be transgender who doesn't have gender dysphoria, and you can have somebody who's gender dysphoric who may not grow up and be transgender. And yet there's no diagnostic criteria for transgender other than a person saying I'm transgender.
Well, with regard to, terms, so for example, in DSM-3, there was gender identity disorder of childhood, and then transsexualism for adolescents and adults. That continued in DSM-3R in 1987, but in DSM-4, we just collapsed the two labels and just called it gender identity disorder and just had different criteria for children versus adolescents and adults. And then in DSM-5, the term was changed to gender dysphoria. Now, I worked on the DSM-3R, the DSM-4, and the DSM-5, and my view is, diagnostic labels aside, the criteria are more or less similar over the different iterations. But what I would say is transgender has never been a diagnosis. Transgender is an identity label. So, I might see a 16-year-old who says I have gender dysphoria, but they don't self-label themselves as transgender because they might say, I'm just a boy or I'm just a girl. And sometimes kids will say to me, I need you to diagnose me with gender dysphoria to prove that I'm transgender.
Right.
And usually what I say is, transgender is a subjective identity. Doesn't matter if you meet the criteria for gender dysphoria or not. But I also say, I diagnose gender dysphoria. I don't diagnose identity.
Right, because identity is it's pretty hard to even define. I mean, it's a label. Like as I was talking earlier, I identified as a liberal for most of my life, but now I've been told that because of my speaking out against conversion therapy bans for children, I'm no longer a liberal. And so it's interesting to me how society puts labels on us, and we put labels on ourselves, and sometimes society will put labels on us that we reject, and vice versa. And it does get very confusing because I say to people, I don't identify as a cis woman because, especially because of my childhood gender dysphoria, and because I am a quirky woman, I would never claim that identity as that I perfectly align with my biological sex, because I have these areas in which I love number patterns. I get really excited about number patterns. Most women don't do that. I read science fiction as a kid, and most women don't do that. And so when somebody says that I'm a cisgender woman, I find it, I sort of bristle at that, because I feel like they're pushing an identity on me that I don't feel myself. And yet at the same time, people are saying we have to accept they're putting an identity on us, and also accept their definition of their identity. So I guess it is basically very political.
Right. Well, Soviet psychiatry would put political dissidents in mental hospitals. Hopefully, if you're now labeled, to the right of center, that won't become a diagnosis in DSM 5.1.
It might.
But you never know.
You never know.